like to invite Dr. Radhika Natarajan for her talk, which will be on the use of anti-segment OCT in corneal diseases and corneal disorders. Dr. Radhika. Can I request the next speaker to be ready, Dr. Sheetal? Are you ready with the talk? Thank you. I would like to request all speakers to just kindly try to knock off a couple of minutes, otherwise I think we'll not be able to complete the session.
We'll certainly do, Dr. Hamid.
Thank you so much.
Thanks for having me over here, Mr. Munish and My Healthscape, and good afternoon to everybody. So I'm Radhika from Natarajan. I'm going to quickly take you through some situations where the ASOCT and MS39 in particular have helped me in clinical diagnosis and treatment. I'm going to be dealing with the ASOCT part of the ensemble. We know it provides an optical biopsy of the cornea, and these are some cases where it has really helped me. This is a patient with a long-standing corneal scar who came with a central melt. Now, if it is well epithelialized, I need to wash, but if it is not, it's going to melt. Fluorescein will only pool, it won't tell me about epi defect. So the ASOCT over here, the MS39, has clearly shown me the continuity of the epithelium, showing me that it is a quiescent process and I don't need to do a surgery in an eye that is not seeing. So this is a case of infection, corneal infection, Mycobacterium keratitis. You see a smallish kind of infiltrate with hypopyon. The end-on view does not show anything beyond, and the side view also, the cornea is very edematous. I could not make out the endothelial exudate. But here the ASOCT clearly shows that it's actually reaching up to the lens where the arrow is pointing. It's a deeper infection than we thought, and that helped us further in the treatment. And with the medical management, you can see the resolution in the subsequent OCT. So these two corneal scars look very similar. One is a Reese-Buckler dystrophy, the other one is a Salzmann degeneration. But if you see the OCT, the first one, the anterior stroma, is uninvolved, whereas in the second one, in Salzmann, there is an irregular stromal scarring. So that decides the treatment, whether you want to do a PTK or whether you want to do an anterior lamella keratoplasty. So keratoconus, as has been pointed out, shows the donut-type thickening of the epithelium. I'm not going to repeat that, but what I want to show you is that in an advanced case, there is an alteration of epithelial thickening overlying the cone, because there you have scarring and the thickening pattern varies, changes, is what I want to show you. When this keratoconus progresses further, all topographers will fail you. You'll see blotches of red. You won't know how the keratoconus is progressing. But then if you do the OCT, you see disruptions in the Bowman's membrane. And if you closely observe these over a period of time, you know that the advanced keratoconus is advancing further or not, because then either you continue with the Pros contact lens or you opt for DALC as a procedure, depending on the progression. When it eventually breaks down into a hydrops, there also we have this instrument which facilitates our management. You can assess the extent of the hydrops and decide on putting the compression sutures, but that's not what I want to show you. Ironically, despite the hydrops, the central cornea is very thin. So you need to know where to place the sutures. This patient underwent hexagonal compression suturing, and the results are here for you to see. And this is a single-eyed patient with keratoglobus, and the treatment for keratoglobus is usually a limbal sparing lamella keratoplasty. The patient gave history of injury. It was impossible to assess his Descemet's membrane. He was very photophobic and anxious in the single eye of his. And here the MS39 has shown multiple DMDs following the trauma. So an anterior approach keratoplasty alone will not help in this condition. And this is a patient with peripheral ulcerative keratitis. You can see extensive thinning in the periphery. So do you want to jump in and give immunosuppression to this patient? If you take a minute to see the MS39 picture, the area of thinning is wafer thin, but it is very well epithelialized. Again, the disease process is quietened over here. You don't need to immunomodulate this patient unless there is a recurrence of activity. So this crab claw, as has been pointed out earlier, may show that this is a PMD, but actually the map is a short one. It's an 8mm map. So if you see the ASOCT, then you know that this is a pellucid-like keratoconus, whereas in an actual pellucid marginal degeneration, you see extreme peripheral thinning. So you can have a diagnosis at your hand. And here you see, even before the cornea has decompensated, some amount of railroading and thickening of the endothelium, which is showing that this is a Fuchs endothelial dystrophy. And in the interest of time, I have multiple clinical cases like this, where it's not been an ancillary tool, but has actually helped me in the management. But what I want to conclude saying is that not only in these clinical patients, MS39 and other OCTs, I have a fair share of other OCT pictures also, have helped us a lot in substantiating our findings in all of these publications as well. So I'll be most happy to take outside this hall to whoever is interested the sharing of the other cases where this device has helped me in management and treatment. I hope I complied with your request.
Fantastic images and wonderful presentation. I think Dr. Radhika